and up again. Where exactly do you feel it?
When I go.
Oh, I mean, where about in the knee? On the front. Okay. He's a physiotherapist, he's diagnosing himself. Yeah, he feels it, he's a patient, but he just says inside, that it is the cartilage, the posterior cartilage of the femur, of the patella, which is the thickest cartilage on the body. Good. I will do the following. I've got too many tests on my back, but I use tests that can guide my treatment. Does it make sense? What's the value of Hawkins and Kennedy test for the shoulder? What's the value of Hawkins and Kennedy test? Do you know it? Shoulder test. It says what? Provocation. It says what? What does it tell you? Nothing. It tells you that this patient has shoulder pain. We did a systematic review in 2010 at Sheffield Hallam. Hodges did 2 systematic reviews. Reliability of shoulder test is nothing. It just tells you this patient has a shoulder pain. Really? He's been here in the 15 minutes in the waiting area. He's coming because shoulder pain. So to do this, positive, oh, well done. So what? It does not guide your treatment. But if I do active range of movement, and the patient has pain at this point, and then I do passive range of movement, and the patient has no pain with the passive range, this is a helpful assessment. Why? Because it says active range is limited, it is a muscle. Passive range is pain-free, it's not a joint. That means my treatment should be to work on the muscles. But if active range of movement is limited and painful, passive range of movement is limited and painful, it means joint and muscle, I have to work on the joint, I have to work on the muscle. This is a helpful assessment because it guides your treatment. Does it make sense? We need to change our beliefs about a lot of things. We inherited a lot of things that doesn't make sense.
So why are we still using this kind of names?
Is a question that
and
we
the
ask.
physician insisted to put this name in the referral, positive Hawkins test, positive Nearest test, positive
I can send you the evidence. Take the evidence to them.
Of course I applied that I could touch this and I found it positive, but you can't guide me which muscle exactly, which tendon exactly.
It can't guide you to is it muscle or versa or both. Even if it does, if I do any one of these tests right now for all of you guys, the research says 72% of the asymptomatic population will have shoulder test positive.
Yeah.
What does it mean? Are we treating a test or are we treating a symptoms? We're treating a patient. Anyway, so back to Hassan. Sorry, I kept you waiting. Soften your knee. That's it. And relax. Just you need to relax this. I need the quads to relax, please. If I push the kneecap in, you follow me, and ask Hassan to squat, and he said the symptoms is getting less. What does it mean? It is my tracking. What's the evidence? When I try theoretically to correct the tracking, symptoms is getting less. This could be an indication to have a small piece of tape and push the patella in. It's not going to last forever, but at least to give him this kind of progressive input. But he must join John on the same exercise.
If not,
I will give you, I got too many options. I never give up.
What difference between John and Hassan?
There's no difference. I'm just using them in 2 different ways.
Okay.
You have to show you that we can look at things in different ways. Ready, listen? Relax for me, please. Now, squat, please, gently. And up again. Worse or same or less? Less pain. What does it mean? Correction. So I got 2 options. John's option, which is bring the femur back by activating the glutes, but also I can add the taping to help. And we definitely need to stimulate the quadriceps, not just the VMO. So work through the whole range. The theory of last 15 degrees, it has no evidence behind. Right? Is it okay?
I will ask one question.
The main problem here, where gluteus medius or
Chicken or egg?
Chicken or egg. Yeah, that's true.
So you
Yeah,
got two
either
options.
way.
You got two options. Find the wall and hit your head on the wall, trying to find the problem.
Yeah.
Or you know for the mechanics, it is a double problem. It could be the track or the train. I would correct the train, but also I would correct the track.
Yeah.
Isn't it simple?
Yeah.
Like two birds with one stone. It's like two birds with one stone.
Exactly. Exactly. Yeah, that's a good said. Okay. Shall we do that?
Excuse me, why don't you make the differential diagnosis for this maybe the other, maybe chondromalacia, patellar femoral tendinitis,
Okay.
or chondromalacia in this case? Why don't you make the test?
What's chondromalacia, doctor?
It's roughness of the posterior surface of the patella.
We call this medical diagnosis.
Yes.
Medical diagnosis. Do you know what's the problem? And please don't get me wrong. I have people more experienced than me here in this hall. But my interpretation of our major issue at the moment, our profession is really young. We are not physics, we are not chemistry. We're just 60 years old, right? So when we born, we didn't know exactly which way to go. So we tried to find a role model to follow. What's the best role model? Was orthopedist, doctors, okay? So we asked them, what do you do? They said, we do testing, so we do testing. What else? We give a diagnosis. We will try to give a diagnosis. What else? They send for scanning, we can't. They do inject, we can't. They do surgery, we can't. So we ended up, we are trying to focus more on assessment and diagnosis to give the patient a name, and we forgot our name, physiotherapist. So I'm trying to make it simple. If you can come up with a very gentle and very brief idea about what's going on, who cares about the name? I will give it another name, I will call it knee dysfunction, who cares? So what's your translation of this word? Knee dysfunction? Knee dysfunction, our colleague Hassan, when he squat, he feel knee pain. From my brief assessment right now, it is glutes and it is patella. I will work on both, everyone is happy. By the end of the day, you care about your knee pain, you don't care about the knee problem, Hassan. Yes. Same our patients. Same our patient. Okay. Shall we do that? I'm not saying, don't get me wrong, I'm not saying...
No.
It
But
just-
you mean that you can work to just only to arrive to the result, good result, but without diagnosis.
Without really focusing on, again, patient coming to me,
Can make
patient with
test and expect
back pain.
This one, so
I'll make it simple by comparison. Patient with back pain, bilateral symptoms on the lower limb, difficulty passing urine, sexual dysfunction. This is a medical diagnosis. This is a code requirement. Go to A&E. Go to the emergency department right now.
Yeah.
This is a medical diagnosis.
Yeah,
No one can
that's
talk
it.
about it.
Yeah.
Patient with bilateral symptoms are, he can't hold this, weakness of the small muscle, and ataxic gait. This is myelopathy. This is a medical diagnosis. Do you know what I mean? But mechanical problem,
Yeah.
it's a mechanical.
Yeah.
And if I see a mechanical problem, I smile. Because mechanical problem, the treatment should be mechanical.
Yes.
Yeah? Is it okay?
Yeah.
All right. Good. Hassan. I prefer to take Hassan from loaded position because he's an active guy and he feels symptoms during work. Okay, which means I prefer to take you while standing. Just a moment. Okay. Soften your knee. That's it. Now, just squat very gently again. Same. This means I can add one more. Good? If I add one more, or I use longer one, but I add more
Stretch.
more stretch. Good. With? Yes, yes, exactly. Good. So did you get my point that I can use tape as an assessment? Which
Yes.
means
Yes.
if I add the tape and ask him to squat and the pain is getting less, it means the patella, the train, is not running well over the track. Good. What if طب عندنا elastic band extra band؟
Yes.
Yeah.
That is crepe bandage only.
Theraband.
Ah, Theraband? He's asking for Theraband?
اه elastic band.
Women through.
أي لون؟ Band right now. Good. And look. Feel it coming. It's coming. You should look. Listen, come here, please. Okay. Now, if I ask Hassan to squat again, I will ask him to push against the band. يعني لا يعني خمس يعني تجيب رجل
اعمل abduction.
Exactly, that's it. Now, if I ask Hassan to do squat again, and the symptoms get less, what does it mean?
That,
John,
my position.
wait, we'll ask the expert. John, if I ask Hassan now to squat down, while he's doing resisted abduction, AB abduction, and he feels resistant abduction of the femur, yeah? And he feels less pain, what does it mean? Glutes. Because now I'm activating the glutes.
Yeah.
This means I'm trying, when you activate the glutes, the track
Yeah.
will be realigned.
Yeah.
Let's see. Nice game, isn't it? Do it for me, please. And up. Less pain. So you know what you have to do now? Glutes. Glutes this side. Is it okay? Good.
A question.
Can let him external
Come.
rotative.
Most of us are asymmetric patients or asymmetric people.
Yeah.
Sometimes we have like shorter abdomen than the other. If we have athletes having this issue, what can we do with them?
Oh, that's a big question.
Yeah, like shall we just training that shorter part more than the other part?
I have too many questions before I answer this question. Is this shortening due to what? Is it muscular or bony?
Only.
In this case, whatever you will do is not going to make an effect without shoe and sole. Number one. Number one. Number two, after having shoe and sole,
Yeah.
and still having symptoms, it means I need to train the whole muscle chain, and there's another course. Right? There's another course to train the chain, right? Which means I'm not just training the glutes, I'm giving my patient exercise to include the glutes, quads, lats, and top scapular muscle. Anyway,
So just a shorter question. Will you train that short part more?
yeah, absolutely, yes, yeah.
Absolutely.
Yeah. But again, it's a bony one. It's Hassan. It's fine. خلاص. So you know what you have to do now. Okay, sure. What is short? So